After a mastectomy, there are really three basic options that can be elected for in terms of reconstruction or closing the mastectomy. First one, if we kind of look at the most basic, is to have no reconstruction, and that sometimes is known as a flat closure, trying to get things as flat as possible with no intent to reconstruct the breast at that time.
Yeah. Another option is an implant-based reconstruction. Not all patients choose to have a flat closure, but some other techniques may not be appropriate for them, which leaves us with implants. We always talk to patients about the risk for breast implant illness. We do not place implants below the muscle. We do what's called a prepectoral reconstruction with the implant above the muscle. I think for a lot of reasons, people have a lot less pain. I think the infection rate is lower. We don't know how the BIA symptoms are affected in the prepectoral patient, but it's always a conversation to talk about BIA and those types of implant reconstructions.
And if patients have the desire to have a reconstruction and are really looking to have it without an implant, natural tissue is almost always an option. I feel like sometimes natural tissue is left as an option for specific situations, but actually I think it's almost always an option. There are a few scenarios where tissue may not be available, but the most common place we use tissue to make a breast out of natural tissue is the lower belly. It's called a DIEP flap, DIEP flap. Yep. That's the most common location, but there are other places. Some people sometimes are too thin in their abdominal region, so we can go look other places. The thighs sometimes are a good location to get tissue. The inner thighs offer us flaps that are called the PAP and the tug flaps. The buttocks, the gap flaps, GAP flaps. So there's a lot of tissue areas on the body where we can borrow tissue and microsurgically move that tissue up to the chest and rebuild the breasts. And like we've said before, all three of these options, these are things that can be done at the time of the first surgery, but they can certainly be done if nothing is done. They can always be visited at a later date. And I think another very important thing that happens is a lot of people have reconstructions that they may not be happy with, and there are always ways to look at improving a reconstruction as well. So,
and about a third of our patients are people who've had problematic reconstructions. Both Dr. Kocak and I are microsurgeons. We trained in microsurgery for breast cancer reconstruction, so we've got the ability to offer a lot of options that patients may not get